Ventricular tachycardia. Brief description. Ventricular tachycardias are wide QRS tachyarrhythmias that originate in the myocardium. They are commonly associated with some form of structural heart disease. Clinical significance. Malignant, potentially lethal arrhythmias, sustained ventricular tachycardia (VT) and ventricular fibrillation. Non-sustained, hemodynamically tolerated arrhythmias. Premature ventricular contractions (PVCs). Non-sustained ventricular tachycardia (NSVT), and accelerated idioventricular rhythm (AIVR). A ventricular tachycardia which stays for more than 30 seconds is labeled sustained. All wide QRS, greater than 120 ms, tachycardias are considered and treated as ventricular tachyarrhythmias until proved otherwise. Treatment. Objectives of treatment. Prevent degeneration of ventricular tachycardia to ventricular fibrillation. Reverse cardiac arrest. Non-pharmacologic, CPR should be provided to patients with sustained VT with cardiac arrest. The victim is unresponsive, pulseless, and not breathing. O2 via face mask or nasal catheter. Continuous ECG monitor. Suction device and endotracheal intubation set should be ready. Correct electrolyte disorders. Reassure patients with non-sustained ventricular tachycardia. Defibrillation, DC cardioversion. Sustained polymorphic VT, ventricular flutter or ventricular fibrillation. Emergency defibrillation, without synchronization, with greater than 200 joules, monophasic, increase the energy to the maximum if arrhythmia persists. Sustained monomorphic VT, synchronized with greater than 200 joules, monophasic. Note: if the hemodynamic status allows, conscious sedation should be provided. DC cardioversion is first-line therapy for sustained wide QRS tachycardias. Pharmacologic treatment may be an acceptable option in hemodynamically stable monomorphic VT with no heart failure. Pharmacologic. First-line, intravenous amiodarone. Stable VT regimen. Step 1, 150 mg over first 10 minutes, dilute in 100 ml D5W. Step 2, 360 mg over next 6 hours, dilute 500 ml D5W 1 mg per minute. Step 3, 540 mg, dilute in 500 to 1000 ml D5W, over next 18 hours, 0.5 mg minute. Pulseless VT, cardiac arrest, regimen, if unresponsive to defibrillation attempts and CPR. Amiodarone, IV push, 300 mg, undiluted. If VT or VF recurs, administer supplemental dose of 150 mg and continue CPR. Alternative. Intravenous lidocaine, both stable VT and pulseless VT, cardiac arrest regimen. Lidocaine, IV, 1 to 1.5 mg per kilogram. Repeat with 0.5 to 0.75 mg per kilogram every 5 to 10 minutes if no response. Maximum cumulative dose, 3 mg per kilogram. Follow with continuous infusion of 1 to 4 mg per minute. Preparation for continuous infusion. 2 grams of lidocaine, 250 milliliters D5W. Rate of infusion. 1 mg per minute equals 7.5 milliliters per hour. 2 mg per minute equals 15 milliliters per hour. 3 mg per minute equals 22.5 milliliters per hour. 4 mg per minute equals 30 milliliters. Prevention of recurrence. Non-pharmacologic. Standard treatment of the underlying cause is the mainstay of treatment for preventing recurrent VT, e.g., treatment of acute coronary syndrome. Correct precipitating causes, e.g., hypoxia, hypo/hyperkalemia, acidosis, pulmonary embolism. Discontinue arrhythmogenic medicines, digoxin, antiarrhythmic medicines. Pharmacologic. First line, amiodarone, PO, 800 to 1,600 mg per day in 2 divided doses for 1 to 3 weeks. When adequate arrhythmia control is achieved, decrease to 600 to 800 mg per day in 1 to 2 doses for 1 month. Maintenance, 400 mg per day. Alternative or additional to amiodarone, beta blockers, metoprolol, extended release, PO, 25 to 200 mg per day, or atenolol, 25 to 100 mg daily. Refer the patient to next care delivery after stabilization is strongly recommended.